Okay, so we are already live, and with all your concern, I'm starting the session. So, good afternoon, and a warm welcome to all the dignitaries present here. Myself, Rupsha from ClearNet, assigned as a session assistant to ensure a seamless experience. ClearNet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that ClearNet is a digital partner of this event organized by National Neonatology Forum, Gujarat, and the topic of today's session is case presentation on perinatal asphyxia. So let's begin today's session, for which I would like to give the handover to Dr. Kunal sir. So, sir, please proceed with your talk, and over to you.
Yeah. Thank you so much, Rupsa. So it is a great pleasure to meet you all on this Neonatal Pathshala platform, which we conduct on every Wednesday between 3 to 4 p.m. So today we are having a case presentation on perinatal asphyxia. Dr. Prachi Thakur will be doing so. So as an expert, we have Dr. Anuj Grover with us. Now, thank you so much, sir, for joining us. Before starting the session, I would request Dr. Shwetal Bhatt, ma'am, our President, Gujarat State NNF, to say a few words.
Thank you, Dr. Kunal. A very good afternoon to all. As NNF Gujarat is committed to touch all the stakeholders of neonatal care of Gujarat, and our postgraduate students, future budding neonatologists and pediatricians are part of the stakeholder team of neonatal health of Gujarat. So we conduct case presentations, we nurture them, and on the same, we have today Dr. Prachi with us from third year resident from Baroda Medical College. And thank you so much, Kunal, that we can organize such case presentations and academic sessions by your constant efforts. I would like to ask Dr. Nitin to introduce Dr. Anuj, our expert faculty.
Yes, good afternoon, everybody. So we have Dr. Anuj Grover with us as a chief expert for today's case presentation. Dr. Anuj Grover is MD, MRCPCH and FRCPCH from UK. He is a consultant neonatologist and director at Setu Newborn Care Center at Ahmedabad, which is a 50-bedded facility, tertiary care facility with NNF and IAP accredited units. He's a certified NLS instructor and a simulation trainer. He is an examiner for MRCPCH exams in India and a co-director for NEST and NeoSim simulation workshops. He is a founder trustee of KMC Foundation, and his areas of interest is KMC, neonatal transport, advanced ventilation, and simulation training. We have Dr. Prachi Thakur as third year resident who will be presenting the case. Over to you to Dr. Anuj Grover and Dr. Prachi Thakur.
Good afternoon, everyone. Thank you very much for the kind introduction, Nitin. Pleasure to see you all. Many thanks to Shwetal and Kunal for inviting me for today's session. Without wasting any more time, I would request Prachi to please begin your case presentation, and then we can have a discussion with this. Thank you very much.
Good afternoon, everyone. I'm presenting a case on perinatal asphyxia. The case is about a baby of XYZ born out of non-consanguineous marriage, a female child born on 22nd July at 5:10 p.m. With LSCS, and the birth weight was 2.8 kg. The parents were a resident of Bajwa village, mother being educated up to 8th standard, and the father is educated to 10th standard. Is a daily wage worker, and the family income being 8,000 rupees per month, belonging to lower middle socio-economic class according to modified Kuppuswamy classification. In antenatal history, the maternal present age is 24 years and the age at marriage was 18 years of age. She's a third gravida. First baby was a full-term male child, presently 5 years of age, delivered by vaginal delivery. The second baby is a full-term male child, delivered by vaginal delivery, and presently is a 2.5 year of age. The LMP being 15th in 2023 and EDD was 22/7/2024. Pregnancy was detected by urine pregnancy test at 4 weeks of amenorrhea and was confirmed by first antenatal USG at 6 weeks of gestational age. In first trimester, the first antenatal USG was done at 6 weeks and folic acid supplementations was started. The mother did not have any complaint of vomiting, fever, radiation exposure, teratogenic drug exposure, or any rashes. In second trimester, anomaly scan was done at 18 weeks and it was within normal limits. Mother was diagnosed with preeclampsia and was started with tablet labetalol. Fetal movements was appreciated since the fifth month of pregnancy. Iron folic acid and the calcium supplements were started, and two doses of TT 1 month apart were administered to the mother. In third trimester, two USG scans were done, one at 7th month and one at 8th month. Both were within normal limits. The mother did not have any history of fever, leaking per vaginum, bleeding per vaginum, any complaint of UTI or rash, convulsion, or blurring of vision. However, pedal edema was noted in the mother. The mother developed
What
labor
was the
pains
cause of the
at
pedal edema?
so it was with preeclampsia. That was along with preeclampsia, proteinuria was there, so that was the
Yeah,
cause of. In the natal history, the mother developed labor pains on 22nd of July at 11 a.m. and she was taken to the nearby CHC. And the non-progression of labor was noted, and she was referred to SSGH after 5 hours. That was at 4 p.m. She was received at a setup, and portable CTG was done, which revealed fetal distress with a tachycardia of 180 beats per minute.
Sorry,
Along with
just
that,
a second.
maternal.
Prachi, just a second. So, portable CTG revealed fetal distress with tachycardia of 180. So, what are the criteria on the CTG where you can say there is fetal distress? Is it only fetal tachycardia or anything else that you can see on there?
No, sir. It can be fetal tachycardia or bradycardia. Fetal heart rate more than 160 beats per minute or less than 110 beats per minute. Along with that, beat to beat variability, the normal being 6 to 25 beats per minute. If it is more than that or less than 6, it is also suggestive of fetal distress. And there has to be normally accelerations are present, but if there are late decelerations present or a variable pathological deceleration is there, that is also suggestive of a fetal distress.
So, what do you mean by late decelerations?
Late decelerations would mean that after the onset of uterine contractions or either after the completion of uterine contraction, the fetal heart rate deceleration would start. It would mostly because of uteroplacental insufficiency, and the deceleration should be at least 15 beats per minute, and it should come back to the normal baseline at least by 15 seconds. That is a late deceleration.
Okay, fine. So, in this case, there was only fetal tachycardia.
Yes, sir.
Okay. Please proceed.
The maternal BP was noted to be 180 by 110 mm of Hg. Emergency LSCS call was taken for fetal distress with non-progression of labor, and a thin meconium stain liquor was present.
When did
The baby
her
was
membranes rupture?
when the mother was received at SSGS. At that time, sir, membranes were ruptured.
And at
Within
that
half an hour,
time, there was a meconium noticed, was it?
yes, sir, thin meconium was noticed.
At 4 o'clock.
Yes, about at 4:30. Half an hour the mother took to get to her place. When she was referred, at that time meconium was not there. The patient was delivered on 22nd of July at 5:10 p.m. with emergency LSCS with a vertex presentation. Thin meconium stain liquor was present, and the birth weight was 2,800 grams. During the time at the time of delivery of the baby had not cried. The baby was not breathing and was a full-term baby. So immediately clamping of cord was done and initial steps of resuscitation was done. There was no spontaneous breathing following that, after which positive pressure ventilation with bag and mask was started with roommate, and the patient was monitored with the SpO2 for next 30 seconds and initiation of breathing. But even at 1 minute, the breathing was absent and heart rate was more than 100 per minute. The patient was intubated with an endotracheal tube of number 3.5 as a non-establishment of good spontaneous respiration was there.
What was the heart rate at birth? At 1 minute, you said the heart rate is more than 100.
Yes, sir. Sir, according to NRP guidelines, when the baby is delivered, first whether the baby has immediately cried or whether the establishment of respiration is there or not, that we assess. If it is not present, first of all, we start with our initial steps. We don't see the heart rate at that time. Then after 30.
So at 1 minute, you counted the heart rate more than 10. 100.
More than 100, yes, sir.
Okay.
Then even at 1 minute, there was no spontaneous breathing established, so endotracheal tube was inserted. The baby was continued with positive pressure ventilation, and here the FiO2 was increased up to 100%. But the heart rate still at 5 minutes, it remained more than 100 per minute, but the baby has weak spontaneous breathing. So the baby was shifted to NICU on bag and tube ventilation for further management of perinatal asphyxia. In the ABGAR, 1 minute ABGAR of the baby was 5, with and then further 5 minutes the ABGAR increased to 6, in which the baby's respiration was gasping respiration that had improved. And on 10 minutes, the ABGAR improved to 7, in which the grimace, spontaneous activity had improved, but the respiration still remained as gasping breathing.
Okay.
Then when the baby was received in the NICU, the temperature of that at that time was 36.7 degrees centigrade, with a heart rate of 150 beats per minute. The respiratory rate of the baby was 84 per minute, and pre-ductal SpO2 with 100% FiO2 was also 81. The CFT was less than 3 seconds. The RBS was noted 162 milligram per deciliter. BP was between 50 to 90th centile. Pulses were well palpable, and cord was not stained with meconium. In the general examination, peripheral cyanosis was present, tachypnea and distress were present, but there was no signs of shock. The Thompson score that was done at that time was 13 by 22, and the Downey's Vidyasagar score was 7 by 10. So the patient was kept on mechanical ventilation. In
What
systemic
were the settings at
examination,
that time? Your saturation
yes,
was 81. So what were the settings on the ventilator at that time?
yes, sir. In settings, the patient was in a PAC mode of ventilation with 100% of FiO2, and FSAT was kept at 35. Pressures were P was 6 and P inspiratory pressure was 18. TI was kept as 0.35 and TE was 1.15 seconds. In systemic examination, the air entry on bilateral side was mildly reduced, and the baby was lethargic in appearance. In CVS, there was S1 and S2 were present, but no murmur, and for abdomen examination was normal. The cord blood gas which was taken, in which pH was 7.09, PCO2 was 65 mm of Hg, PO2 was 28, Bica was 19 millimoles per liter, lactate was 9.13, base excess being -8, and saturation in the cord blood was 24%. It was a respiratory acidosis. At the first hour of
Is that
life, we had
respiratory
also done.
acidosis?
Yes, sir, the pH is less than 10.35. PCO2 is higher on a higher side, but the bicarb is compensating itself, coming almost to normal, that is 19. So, partially compensated respiratory acidosis suggestive of acute asphyxia insult.
What about the lactate and the base excess? What does that tell you?
Lactate and base excess, they are on the higher side, sir.
So what is the normal lactate and the normal base excess?
Normal lactate is up to 3 millimoles, and the base excess can be up to -3.
Okay, so when
Minus or
the
plus
lactate is high and the base excess is also high, what does that suggest to you?
That is suggestive of there is a component of metabolic acidosis or impaired perfusion as well, because peripheral exchange is not happening.
Okay, so tissue perfusion is already compromised. That is why the lactate has gone up. The base excess is high. That is suggestive of metabolic acidosis. So when you say there is only respiratory acidosis, that is not correct. This is a mixed acidosis. There is respiratory as well as metabolic acidosis. Okay.
Okay.
Go ahead.
Then sir, one 2D echo, bedside 2D echo was also done, in which there was dilatation of right atrium and right ventricle with a septal deviation. Interventricular septum was deviated towards the left side, that was towards the left ventricle. A tear jet was present with the normal ventricular contractility, and that was we kept a diagnosis of PPHN at that time. After
So
1 hour of
first hour
stabilization.
of life, Rachi, so this echo was done in the first hour of life?
Yes, sir, first hour.
So dilatation of RA and RB in how many babies at birth or within the first hour of life would you find that?
So it can be a normal physiology also, because usually the transition phase of the blood circulation takes time. In utero, there is a higher pressures on the right side of the heart, that is pulmonary pressures are higher. And that shifting of the pressures would take time. But the clinical features along with the 2D echo findings were suggestive.
When you
They
say
were
the ventricular
corroborating.
contractility is normal and there is only dilatation of RARB, okay, but that
Yes,
is
sir.
normal for a 1 hour old baby anyway.
Yes.
TRZ, what was the, is there anything else you want to elaborate on the TRZ? What is the Vmax on that? Are you aware of that?
Sir, only, no, sir. Actually, we had done only a bedside echo. Later on, after that, the PA pressures and the PA
When you
pressures were
say a
raised after,
TRZ, it
which was
always tells you what is the velocity. Okay, TRZ, when you check the TRZ, it always tells you what is the velocity, what is the peak velocity at the of the tricuspid regurgitation, whether it is a bedside echo or any echo. Anyway, you diagnose PPHN. What are the other diagnostic markers of PPHN that you need at this age to tell you this is PPHN? That the fact that there is a dilatation of RARV or TRZ is there in any baby at birth, okay? Because as you rightly said, the right ventricle or the right side of the heart is the dominant during in utero life. So it is going to take some time for the pulmonary pressures to subside and the dilatation to go down and the TR to go down. So based on whatever you have written, I'm not convinced that there is PPHN. Okay, but what are the other things that is pointing towards PPHN?
So the clinical presentation of the baby was pointing towards it. There was a labile SpO2, preductal, postductal saturation difference of about 10% was present. Even of 100% of FiO2, the maximum saturation in the preductal limb that was recorded was 81.
Postductal. Preductal was
Yes.
81?
Yes. Initially, when the patient was received at that time, it was 81. Later on, it improved, but the preductal and postductal saturation remained, the difference remained 8 to 10%.
Okay.
And there was a labile SpO2.
Okay.
This was the echo which was done at that time, sir.
So tell me which
The
part.
right, so this is the right atrium and the right ventricle are appearing dilated. The interventricular septum is being shifted during the end of systolic motion towards the left ventricle, and bluish
Actually, first
jet.
describe for the rest of the people who are not familiar with echoes, what view was that, and what are the things that you're seeing on that, and then you describe your findings.
Yes, so this is a four-chamber view, in which this is a four-chamber view. Here, midline there is an interventricular septum. On the marker is on the M marker. Towards that there is the left ventricle, and opposite side there is the right ventricle. Lower side there is a on the right there is a left ventricle, left atrium, and on the opposite there is a right atrium. Uh, Right-sided chambers appears dilated in this four-chamber view. When we are adding color to this, this is the right atrioventricular septum through which the normal jet has to be. It should be towards the right ventricle, but the blue colored jet is coming back into the right atrium. That is showing the tricuspid regurgitation jet.
Okay. Anything else on the echo that will tell you there is PPHN apart from the TRZ? What else would you look at in the echo?
We can look for one is pulmonary artery pressures, whether the systolic pulmonary artery pressure and mean pulmonary artery pressure. For
So what is the
systolic
normal one
pulmonary,
and what would you expect in a PPHN baby?
so the normal pulmonary artery pressure, it has to be, it lies between 30 to 60 mm of Hg. So in PPHN, it rises. and we have to compare it with the systemic pressure as well, that is the aortic pressure. If we don't have a direct visual of the TR jet or the pulmonary regurgitation jet, we can estimate it with the level of interventricular septum. Whether the septum, if it is drifting towards the left ventricle, then there is the pulmonary pressures are supra maximal to the systolic pressure. And if it is in midline, that is the D-shaped septum, if it is present, then that means 50% of the pulmonary pressures are more than 50% of the uh, systemic pressure.
Okay, so anything in when there is a you're checking the saturations, okay? You're checking that the postductal saturations were lower by 8 to 10%. What does that tell you in terms of what's going on in the heart?
So there is a shunting which is happening. Two places it happens. One is at the level of PFO and one is at the level of PDM. So we see in PPHN, the shunt reverses, that is right to left shunt would be there.
Exactly.
Because of that differential sinuses is present.
In normal circumstances, you would expect left to right shunt.
Left to right shunt.
In PPHN cases, you will be able to see right to left shunting. So that is something you need to comment on your echoes, not just looking at the TR or the Boeing. Okay, a little bit of TR is normal. Even if there is a little bit of TR, they may not be intracardiac shunting so that your saturations will not be lower. Okay, the fact that your postductal saturations are lower by 8 to 10%, that suggests that there is right to left shunt happening somewhere, either PFO or ductal or intrapulmonary level. Okay, once you have that, that means there is PPHN. With the presence of TR, that doesn't mean there is PPHN. TR jet could be there at 2 meters, 3 meters per second, and yet you will see left to right shunt. Then you won't see low saturations in that case. Okay, go ahead.
This was the X-ray which was done while at the time of receiving the baby in NICU. This X-ray shows bilateral, the lung expansion is up to 7 to 8 rib spaces. It's visible. The ET tube tip is present at the level of T1, T2 vertebra. The cardiac shadow appears to be enlarged, shifting it towards the left side. Right side, thymic shadow is also present. There was thin MSL was present in the history, but no signs of meconium aspiration is there in this baby.
You mentioned that the cord was not meconium stained.
Yes, sir.
So meconium doesn't seem to be the main problem then.
Yes. In the initial ventilatory settings, the mode of the ventilation was pressure-assisted control mode with 100% of FiO2. FSET was 35 and PFO was 6 with pre-inspiratory pressure of 18. The inspiratory time was 0.35 seconds and T was 1.15 seconds. We had given initially a bolus of 10 ml per kg, which was given over 1 hour, and then we had started the patient on IV fluids. Milrinone and fentanyl was started, and we had given the first dose, the start dose of aminophylline, as it was a case of perinatal asphyxia, along with first dose of calcium gluconate was given in this baby.
Let me stop you there now. Okay, so you gave a bolus of 10 ml per kilo of 10 saline or dextrose?
Saline bolus.
Saline, okay. And what was the reason for that?
So the bolus was given as the lactate was high, impaired tissue perfusion.
So was that due to any blood loss? The impaired tissue perfusion is due to hypoxia.
Hypoxia.
Okay, so if there is hypoxia and the tissue perfusion is going to be get better now that your saturations are going to get better. So it's not due to hypotension, was it? Did you measure the blood pressure at this point? Okay.
Yes, the blood pressure was normal between 58 to 98 centimeters.
And you mentioned in your initial slides that cap refill time was less than 3 seconds.
Less than
Actually, your perfusion is now good. Okay, so in those cases, why would you want to give bolus? Because your lactate is not high because there is blood loss, there's no impaired blood pressure, not even impaired perfusion right now. So why would you want to give a bolus? Okay, so be wary of giving boluses because these babies will have renal shutdown and you will end up with SIADH very quickly. Anyway, so you started fluids at 60 ml per kilo. Is that the normal routine 60 ml per kilo that you usually start, or do you, in cases of perinatal HI, do you think about restricting fluids at all?
No, sir. At our NICU, we start according to weight. When the patient who is the baby who are more than 1.5 kg, we start at 60 ml per kg per day.
Regardless of the etiology, regardless of the pathology of the baby. Okay,
Yes.
fine. So you started as per a unit protocol at 60 ml per kilo.
Yes.
And the reasons for milrinol?
Sir, as we had on the basis of clinical judgment and our echo, we had diagnosed the patient with PPHN. So we started the patient on inodilator, that's the milrinol.
So why milrinol?
And
Why not something else like dobutamine or dopamine?
milrinol, it acts by phosphodiesterase 3 inhibition, so it will lead to vasodilation of the pulmonary vessels. So that would help in the VQ mismatch, which is happening at the level of ventilation perfusion mismatch, which is happening in the case of PPHN. So that's why we start with milrinol. Also, milrinol increases. It is also it increases the cardiac contractility as well with an inotropic
There's
as
an
well as a
inotropic
loop.
action and there is a vasodilatory action.
Yes.
Okay. The reason for fentanyl and aminophylline?
So fentanyl was given for sedation as the patient was intubated, and we also and as the patient also had PPHN, so we have started with fentanyl. Aminophylline we are giving in case of perinatal asphyxia as it's is an adenosine. It is an adenosine inhibitor, so it improves the renal perfusion and the early renal insult, which occurs in case of perinatal asphyxia.
Is there any evidence for that?
Uh, Previous text mentioned that it was used previously. In our NICU, we have a protocol so that for every baby with perinatal
Every baby with
asphyxia, we
HI,
give
you give
them.
aminophylline.
Yes, sir.
And do you give maintenance as well?
No, sir, only a stat dose. We don't keep it for maintenance.
Okay, so stat dose of how much?
6 mg per kg per dose.
Okay. And calcium gluconate was given as a bolus as well.
Yes, sir. It was given over 20 minutes, a slow bolus of 2 ml per kg per dose. It was given initially. Then after the INS calcium reports, if it suggests that there is a symptomatic hypocalcemia, then we keep it in under maintenance.
So was the calcium low on the blood gas?
No, sir. For this patient, the calcium was normal.
So the reason for giving calcium gluconate injection was?
Sir, in cases of it, initially the single dose we give it as a before starting any before giving sending any samples. The cause is hypocalcemia can be a precursor to the convulsions which are occurring. It can add on to that along with
And you
because
do?
of early.
So you've done the blood gas before giving the calcium?
Yes, sir. Yes, sir.
So what is the calcium, ionic calcium at that time on the blood gas?
Sir, ionic calcium was not mentioned in that blood gas. For that, we need to send serum samples. So we had only done a FOD pH at the receiving time. The second prick which we have done, that is at 6 hours of life. At that time, the arterial blood gas was sent.
Okay, fine. Go ahead.
Coming to the 6th hour of life, at this time, the uh, ABG of the patient was with a pH of 7.24, PCO2 was 31, CO2 was 70, and a bicarb of 12.1. With a lactate 3.8. The oxygenation index at this point was 18.6. The patient's FiO2, we tapered it from 100 to 80%. FSAT was 32 and the pressures were 6 by 18.
Okay, wait a second. So at the 6 hours of life, you have a blood gas of pH of 7.25. So what does that gas tell you? What is your interpretation of that blood gas?
So this is a metabolic acidosis. The bicarb is low, the pH is on the lower side, and PCO2 CO2 is also on the lower side, that is a 30, which is less than 35. So secondary to metabolic acidosis, there is respiratory alkalosis is happening. CO2 washout is happening.
Okay, so what did you change in your after the first blood gas? Your cord gas or the first blood gas that was showing mixed metabolic as well as respiratory acidosis. Okay.
Yes.
So what are the ventilator changes that you do? The ventilation settings were exactly the same, it seems, 18/6, apart from reducing the FiO2 a little bit. But PaO2 of 70, is that good or low?
PaO2 are between 60 to 80, not more than 70, because it would secondary, it would lead to free radicals, and that would lead to secondary vasoconstriction, which will worsen our PPHN. So that has to be kept on the lower side. According to PaO2, we have reduced our FiO2, but the PaO2 was 70. In front of that, the patient saturation, it was between 90 to 93. Saturation was not beyond going beyond 95%.
Okay, so what were your target saturations?
It was between 90 to 95%, sir.
Okay. But you mentioned OI of 18.6. What does that tell you?
That is a oxidation index of 18 point. In a case of, if it is more than 15, that suggests that there is a gross ventilation perfusion mismatch is happening, and in that cases, it gives us an indication. As in case of PPHN, we can give a trial of nitric oxide, or we can start with vasodilators, in which case we are started with milrinone. If OI further worse.
You've already started milrinone before, no? You've
Yes.
started the milrinone at 1 hour of life.
Yes.
And at 6 hours of life, you have an OI of 18.6. So what changes in your treatment did you do to reduce that OI?
Sir, at this point, we have not changed anything as such. We have just continued with our milrinone and fentanyl, and the treatment which we were continuing before. Just that only FiO2 we have preferred. We have not changed anything else.
Why did you reduce the FiO2 if you have an OI of 18.6? If you have an OI of 18.6, should you think about reducing the oxygen or keeping it the same? You have a problem with oxygenation, no? If you have an OI of 18.6.
Yes. Sir, as our target saturation was being maintained on the SpO2, so that's why we had, according to that, we have titrated our FiO2.
So, well, if you're targeting the saturations only, why did you do the blood gas? If you're going to take a decision only on the saturations, your CO2 is low, your oxygenation is just about acceptable, PaO2 of 70, your OI is high, but you don't seem to have made any change in your ventilation anyway. Even between the 6th and after that gas, did you change the rate or anything at all? You're on the PSE mode, so you don't need to change the rate, but you have a CO2 of 31. Are you worried about that or not?
Yes, sir. CO2 washout that is happening, it can lead to reduced cerebral perfusion.
Okay.
If CO2 washout happens, normally we keep it between, in PPHN, we can keep it between 45 to 50, 40 to 50 on a higher side.
So what changes did you do in your treatment or ventilation strategy once you noted a PCO2 of 31?
Sir, when PCO2 of 31 was there, we had reduced our T inspiratory time. Initially, we kept it as 0.35 seconds. P inspiratory we have reduced to 0.3, and T inspiratory, and the T expiratory also, it was initially 1.15 seconds. That also we had reduced, but the F set it was maintained at 32.
So that is not going to, how much of change on PCO2 is that going to make? Nothing. And you will see that your next CO2 is even lower. Yeah, from 31 PCO2, you've gone down to CO2 of 23. You've got 3 blood gases on there with a CO2 31, 23, 25. Okay. What do you think about those CO2s?
All three of them are on the lower side.
They're all extremely low, not on the lower side. They're all extremely low. They're hypocarbia. Okay, when you have that extreme level of hypocarbia, you have to make interventions to get the CO2 higher because that auto-regulates the cerebral blood flow. If you have low CO2 like that, you have cerebral vasoconstriction, and that's why there will be brain hypoxia and PVL, everything like that. So you cannot have a CO2 as low as that and not make any changes in your pressures. Your pressures have remained exactly the same, 18, 18, 17. Okay, so there has to be some intervention that you need to do to reduce, to correct that CO2. Anyway, go ahead.
At between 6th hour of life to 18th hour of life, the UOP of the patient was reducing. It went from 1.4 ml per kg per hour to 1.2 ml per kg per hour. On 18th hour of life, there was no signs of shock, so we had started with the main feeds for this patient. When we went to 30th hour of life, at that time UOP had further reduced, and some crepitations had started, and there was decreased air entry, and ET secretions had become mucoid. We sent one septic screen at that time, uh, in which the CRP was on the higher side. Micro ESR was 18 in first hour. The total counts were increased, and the patient was ventilated. So we have started with first line of antibiotics. At the 40th hour of life, there was persistent metabolic acidosis.
When
Since
you
the
had the
start BICA was
CRP of 96 was there, that was at 30 hours of life, yeah?
30th hour of life.
And that's when you changed. What was your initial antibiotics?
Sir, initially we have not given any antibiotics. At 30th hour of life only, the first antibiotics we have added.
You didn't start antibiotics at birth?
No, sir.
On a baby who is ventilated, who has got severe respiratory metabolic acidosis, you chose not to start antibiotics? Okay. And there is meconium history as well. So there is fetal distress. Do you know the cause of the fetal distress?
The preeclampsia was one condition in the mother that could have led to
How
uteroplacental
can you be
insufficiency.
so sure that there was no early onset sepsis? You started antibiotics only at 30 hours of life. I think
Yes, sir.
that was a bit brave, but anyway. So you started, your first line antibiotics is meropenem and gentamicin.
Yes, sir. At
Is
our
that your unit protocol? Meropenem and
yes, sir.
gentamicin. Meropenem is the first line. Okay.
Yes, sir. That is the first one.
Okay, fine. Go ahead.
At the 40th hour of life, the patient's UOP reduced to 0.8 ml per kg per hour. The capillary filling time was equal to 3 seconds. Heart rate had increased to 170 beats per minute, and the BP of the patient was at 50th centile. There was a weight gain of 200 grams since birth. The birth weight was 2.8 kg. At present, was 3 kg.
So how much
And
the
the
fluid was
patient.
the baby receiving at 30 hours of life? What was the
Sorry, sir.
What was the fluid intake? How much were you giving in terms of fluids?
Sir, at 30 year of life, 75 ml per kg per day total fluid we were giving, out of which
You
we had.
increased from 60 on day 1 to 75 on day 2. That's just
Yes,
as
sir.
a unit protocol.
Yes, sir.
Okay.
There was a reducing UOP. We had sent our RFC in which the urea was 62, create was 2.28, sodium was 142, and potassium was 3.8. The blood urea nitrogen create ratio was 12.7 is to 1. That was less than 20 is to 1. Intrinsic renal injury was suggestive. The GFR was 9.1 ml per kg per minute, and urine routine micro showed hyaline and granular cast cells. At this point, we had we had initially managed the poor we had managed the shock by adding dobutamine. Once the shock improved, we started with peritoneal. We took a call of peritoneal dialysis, and we had started with
At this
the
point,
cycles at 20 ml.
sorry, Prachi, sorry. You started with peritoneal dialysis based on?
Based on the sir higher urea create, the intrinsic renal injury parameter, and the urine routine micro,
But
which
at
was
this
suggested of
point,
high
the
level,
urine output was not zero, no? It's still 0.8 ml per kilo per hour.
0.8 ml per kg per hour. Yes, sir.
And how much of fluids were you giving to this baby at this time, at 40 hours of life?
Sir, at this time also, we had initially we were giving 75 ml per kg per day, but when the patient developed weight gain and the UOP also reduced, we changed the fluid initially to body surface area, and then we took a call for peritoneal dialysis.
So how much did you give as per the body surface area?
Sir, the patients we had given according to 400 fluid according to 400 meters square. So for this patient for a day, almost the approximate amount was about 85 ml per day fluid was given.
Okay. Anyway, go ahead now. PD at 40 hours of life you started.
At the 52nd hour of life, the urea create it was 64 and 2.1. 14 cycles of PD had been done. UOP was still on the lower side. We had increased the cycles to 30 ml per kg per day. The signs of shock had improved. At the 64th hour of life, now the urea create has been improving. The UOP improved to 1.01 ml per kg per hour, and 30 cycles of peritoneal dialysis were completed by this time. The weight loss has also started. The weight at present was 2.88 kg. Almost 120 gram weight loss was there.
20 grams loss.
We started at 3 kg and now 2.88 since the starting of PD1.
Okay, since the starting the PD, okay.
Then around 88th hour of life, the patient again the FR2 requirement of the baby had again increased to 60% than previous readings, and the patient's ET secretions were turning green and it was more thick and viscid, with the culture sensitive to Klebsiella, which was intermediately sensitive to colistin. Blood culture was also suggestive of Klebsiella. In our Pristine, the platelet counts had reduced to 88,000. CRP was still on the higher side. The RFT had improved, but the patient's respiratory distress had worsened. Considering ventilator-associated pneumonia, we had changed over our antibiotic to colistin and levoflox. The platelet counts were on the lower side. We had sent one fungal culture for this patient. Single dose of fluconazole was given, and the cultures were awaited till then.
Hang on, sorry, just go back. So at this point, on the blood gas, what is your interpretation?
The pH is in the normal range. PCO2 is slightly higher, more than 45. PO2 is normal and bicarb is 19. Lactate was also in the normal limit. So compensated respiratory acidosis is there.
Okay, so pH is normal. So this is a reasonably okay gas. You would accept CO2s of 50-55 anyway, except that your PaO2 is still only 70 and you're 60% oxygen. So a little bit of hypoxia, that's all. But on the echo, you're saying resolving PPHN physiology, and yet you have started IV sildenafil in this baby.
Sir, we have changed over from Milrinone to sildenafil. After 72 hours of Milrinone, we changed it over to IG sildenafil.
Why?
Sir, at our unit, if persistent PPHN physiology, if it persists, and if there is a clinical improvement in the parameters of PPHN, so we change over from IV Milrinone to 3-4 days of sildenafil, and then we omit it at the minimal.
Well, that's your weaning protocol from Milrinone to sildenafil and then stop.
And then we stop it.
Okay. Fine.
This was the X-ray which was done at the time when we had made the diagnosis of ventilator-associated pneumonia.
So what is your interpretation of the X-ray?
In this X-ray, the patient is bilateral. There is a homogeneous opacities in the bilateral lung fields. The aerated lung fields have reduced. Initially, it was 7 to 8 spaces. Here, whitish opacity is bilateral. It is present. ET tube is present at the T2 to T3 space, and the PD catheter is seen in the abdominal area.
So what is the diagnosis on base of the looking at the lungs? What is the condition?
So there's a homogeneous consolidation of the bilateral lung fields are present because crepitations and thick viscid renal secretions were also present, which were pointing towards pneumonia.
So that's pneumonia. What about the liver shadow?
Liver shadow, sir, seems to be enlarged.
So what is the reason for that?
Normally 1 to 2 centimeter of hepatomegaly is normal in a newborn.
This is not a normal newborn anymore. No? You have a baby at 88 hours of life who is ventilated, who is got Klebsiella pneumonia, Klebsiella sepsis, increasing oxygen requirements, undergoing PD. That cannot be called a normal variant, can it? Anyway, go ahead.
At the 112th hour of life, at this point, the UOP of the patient had improved, the bilateral crepitations reduced, and air entry improved. The RFT was in an improving trend. At this point, we had given, as the UOP was improving, RFT was improving. After completing almost 80 cycles of return dialysis, we had given a PD rest for the next 24 hours. We were continuing with our antibiotics. On the following day, there was clinical improvement, no further deterioration. UOP was maintained and the RFT was in an improving trend. So we had removed the PD catheter and we had sent the tip for culture. It was suggestive of no further organism growth. The PD fluid was also did not test positive for any organism. We had changed our mode of ventilation to SIMV mode and we are gradually reducing our settings.
So why did you change the mode from PAC to SIMV?
Initially, sir, we were giving sedation to this baby. After that, fentanyl we had omitted, and the patient's FiO2 requirement has also reduced. The distress has also reduced since before. We were planning to wean off, so we had shift from PAC to SIMV.
Okay. So one thing going back, your Klebsiella, the sensitivity
Yes,
was only partially sensitive to colistin.
yes.
What about levoflox? Because that's what you added, levoflox.
Sir, there was no sensitivity plate was no, it was not mentioned for levoflox. Levoflox we had changed when there was uh, worsening in the RFT. At that time, only gentamicin we had removed and we had changed over to levoflox. There was no sensitivity parameter for levoflox, only intermittently sensitive to colistin was present. So
What about
we changed.
meropenem? Meropenem was
No, sir, meropenem was resistant. So we changed over to from meropenem to colistin.
okay.
Uh, on
Did you
seventh
do
day,
any
sir, the
blood
patient was in.
reports, blood report before this? On the because the previous platelet count was 88,000.
Yes, sir. The repeat septic stream was done on 8th day of life, sir. At that time, the
No,
platelets
no
had
bloods before that, no? No platelets checked.
no, sir. In between that, we had not checked. On 8th day of life, we had sent it again, in which the platelet count had increased to 1.6 lakhs. Other than that, the
The
other
CRP?
parameters were CRP, sir, it had reduced to 0.7 milligram per deciliter. And the micro ESR was also normal. It was 5 mm in first hour.
Okay. Fine, go ahead.
Gradually, sir, feeds were increased to full feeds. The patient was extubated, changed over to HHFNC mode. As the Downey score was 3 by 10 on 7th day of life. And later, the patient was off O2 in further 24 hours. Total antibiotics, according to culture sensitivity, had given for 14 days. We had established breastfeeding and gradual weight gain was noted. The patient was discharged on 20th day of life. At that time, the Thompson score of the child was 0 on 22. Birth vaccination were given before discharge. At the time of discharge, the general examination of the baby showed a temperature of 36 and 8 degrees centigrade with a heart rate of 135 beats per minute, RR of 48 per minute, normal saturation with no pre-ductal post-ductal difference of 96%, 97%. CFT was less than 3 seconds and the peripheries were warm.
Go ahead.
With the
Move ahead.
The posture, tone, and activity was also normal. So in head-to-toe
Is there
examination, it
anything
was also
remarkable in that? Nothing else? Then go ahead.
no, sir. Everything was normal.
Go
Even
ahead.
in anthropometry, the discharge was frequent. In the systemic examination, sir, everything was normal. There was no positive finding as per the baby. In our diagnosis, we had kept a single full-term 40-weeker 2.8 kg female child with appropriate for gestational age. The baby was delivered by LSS for preeclampsia with fetal distress, and there was a moderate perinatal asphyxia with NABGAR of 5, 6, and 7, for which resuscitation was given, followed by intubation. The patient had the LICA was thin meconium state, and maternal morbidity of preeclampsia was there. At the time of admission, the patient was under HI grade 2. Further, it had improved, and the patient required mechanical ventilation for 7 days. PPHN and grade 3 AKI required platelet dialysis was there, and the baby had a Klebsiella positive ventilator associated pneumonia.
Stop. So you mentioned moderate perinatal asphyxia and HI grade 2. Okay.
Yes.
But what was your management in terms of HI at all? What is the most effective therapy for HI?
So that is therapeutic hypothermia. In this patient, as there was a PPHN, so it was a contraindication for therapeutic hypothermia. Also, the pH and the base excess. pH, it was less than pH. This patient was more than 7. Base excess was not more than -16. It was -8. And as the baby had PPHN, so we had not kept the patient. We had not considered the baby for therapeutic hypothermia.
But on what basis did you classify this as HI grade 2?
On the basis of Thompson score, sir, the receiving Thompson was 13 on 22. And according to Sarnat staging as well, when the
As
baby
per
was
Sarnat
received as
staging, what were the abnormalities in the baby that put the baby on grade 2?
sir,
So
at
once you say grade 2, once you say moderate HI, that means
yes.
baby qualifies for cooling, yeah? You cool
Yes.
moderate and severe. You don't cool mild. Once you say it's
Yes.
moderate.
Sir, the baby was, according to Sarnat staging, the first 3 points for the baby was hypotonic with lethargic appearance. Initially the baby had a Thompson of 13 on 22.
Thompson is not part of Sarnat. So what are the parts of Sarnat staging?
The level of consciousness, the tone, then the complex reflexes, and the autonomic activity, whether it is sympathetic or parasympathetic predominantly. Along with it,
okay, you need to read that. Okay, because if you say grade 2 HI, then you have to automatically consider cooling. But cooling criteria, as per the standard international accepted norms, what are the cooling criteria?
The baby should be more than equal to 36 weeks of gestation. The baby should fall under moderate to severe encephalopathy. Along with the pH should be less than 7 with a base excess of more than -16 millimoles per liter. And we have to rule out other congenital heart disease, congenital malformations, IUGR baby.
Okay. So apart from the pH and the base excess, now you didn't do, this was the cord blood gas. So you could have done your admission gas when you started the baby on treatment. And maybe that time the baby would have fitted. I mean, in terms of PPHN, this was not a bad PPHN requiring nitric. You think about the baby's future, in the long term, this baby is going to come to harm from HIE because if there is a significant HIE, there is going to be, you're increasing the risks of adverse neurodevelopment because you didn't cool. Okay, so you have to be very clear into why you did not cool. This is not a baby on nitric oxide. So if your PPHN is that bad, I mean, your criteria for PPHN were very loose itself because there was no right to left shunting on the echo that we could see. So don't just base on one particular aspect that there is TR and there is RARV that is going to be there in any baby. So that cannot be the criteria that you, oh, I want to offer cooling for this baby. Okay, so you have to be very specific as to why you did not cool this baby. Okay, go ahead.
On follow-up, the baby was advised there was advice for exclusive breastfeeding and beta-nova D3 supplementation were given. ROP screening at before discharge was done, it was not suggested for any new vascularization, and a 2-week follow-up was given for one screening. And the baby was planned for a BERA at 1 month of age, and 6-week immunization was advised on follow-up along with the Hammersmith scoring on follow-up.
Okay. What specific bits would you be looking at in the terms of follow-up in growth and development? When will you call this baby for growth and development?
So we would be looking for the head circumference, whether the baby is developing microcephaly or not, or we also have to look for the early markers of cerebral palsy, whether there is an adductor spasm or the baby is not. There are babies causing all the danger signs for development, where the baby is not achieving development at age.
So before discharge, is there anything that you can check that tells you about the future likely outcome?
MLT score, we do MLT score we can do, in which the muscular components, the neuromuscular components we check for the baby, and the higher the score, the worse is the prognosis.
Have you heard of something called Practal's charts? Practal's assessment, or a general body movement assessment of a baby? Okay, so you can look at the movement patterns of the baby, the repertoire, or is there a repetitive movement? What's the tone like? And that is because if you see this baby after 3-4 months, because neurodevelopment will be around 3 months of age, yeah? By that time, you should have, this baby is at high risk for adverse neurodevelopment. Why?
Because the patient falling under HI grade 2,
Okay.
moderate
One is HI grade 2.
encephalopathy.
Anything else?
So the baby had also poor NICU. Course was also
So this
the
baby
baby
had
had fallen
very
the
bad sepsis. This baby had a severe AKI injury leading PD. This baby had very low CO2s for a prolonged duration of time. So very high risk for adverse neurodevelopment. So before this baby goes home, I would do this general body assessment by Practal's charts and start early intervention in this baby, not waiting for 3 months for the baby to already show signs of developmental delay. So you have to start early intervention in terms of physio, even before the discharge.
Okay.
Okay.
Yes.
I think we have exceeded our time, Shwetal. Sorry for that.
No issue. It's a learning phase. So it's really benefited. I think we have done with the case, Anuj.
Yeah, I think we are done. Is there anything you want to add, or Kunal?
Kunal, we can wind up.
Yes, ma'am. So, thank you so much, Prachi, for excellently presenting a case. It was tough answering Anuj sir.
Sorry,
Uh,
I was being a bit tough on her, but I was just asking a
No,
lot of
no,
questions.
very valid points covered.
yes.
Right now, our cooling machine is not out of order. So, but the points we always write in the case paper also. So these are the criteria favoring and the availability of equipment and all that. So it's really very
One
much
thing that
required with the
we
era
could
of
have
medical
done,
legal.
Shwetal, I don't know whether you have facilities for cerebral function monitoring at your setup.
No, we don't have that.
Because if you can check on the CFM, you would know how bad the encephalopathy is and whether we should cool on basis of that. So obviously the pH and the base excess is one criteria, but that cannot be
Yes.
the only criteria. pH of 7.0
Yes, yes,
is still
true.
pretty bad.
True. Very well taken.
And
But our machine, our probe is not functioning. We have a critical machine, but we are struggling with the probe aspect for getting repaired. Otherwise, we would have I always ask them whenever there is a perinatal asphyxia baby, write down the points favoring cooling and points against the cooling. Well taken point. And general body movement, yes, that is also one of the important point to be considered inside the NICU. We have physiotherapists who come for the NICU, but he is not so trained for all these things. We'll definitely take up this point in our nursery.
Sorry, a couple of more points I had. Aminophylline, I wasn't sure about the
Yes,
role of
yes.
aminophylline.
That Dr. Anuj, I would like to tell you. Under Dr. Sheila, madam, we had done research in our own unit, and there are further other research also. Other studies are also there that perinatal asphyxia can lead to, in the day 4 or 5, there is an acute tubular necrosis and the renal failure. So, aminophylline, single dose aminophylline has a renoprotective effect. However, that renoprotective effect, Cochrane does not still not support that. But as there was whatever research we carry out in our department, and if we find useful, we continue that
But
as
I
a
have not come
protocol.
across any paper on that. That's why
I'll definitely share with
send
you.
that to me, please.
Yes,
I
definitely.
would also
And in
ask
fact,
your team just to, if you have a case with HI, restrict the fluids to 40 on day 1.
yeah, initially we used to restrict the fluid, but I think with newer guidelines, we don't restrict the fluid. But I'll again review and check.
I think you should restrict because your baby
Definitely.
ended up with renal failure. One
Yes.
reason for that could be excess of fluids. So just
Okay.
revisit
So
that.
you restrict to 60% of the normal?
We restrict to 40 ml per kilo per day when we cool. If you have bad HI, then also we would restrict to 40 ml per kilo per day. Until
Can you
we
share the
output.
evidence?
I'll share that with you.
Sure. Okay. Definitely we'll put this into our protocol. Because previously when we were doing residency, we used to definitely restrict the fluid to 60% of the TFR.
There is going to be SIADH, this baby's urine output is going to fall.
Yes.
So all the more reason to be careful in not overloading the fluids.
Sure. Definitely. Any other suggestions, Anuj?
In terms of the blood gases,
Yes.
blood gases have been
PCO2.
quite frequently, but that CO2 low in a country like in a Western country, if you have 3 consecutive low CO2s and if the baby then end up with cerebral palsy, you will be called negligent.
Okay.
That's the Western country criteria, that if the lawyers find out that you've had low CO2s persistently and the baby does adversely neurodevelopment, then they are likely to sue you.
Okay. That part also will take care. I think so this I had kept what it is because I want my resident to this PCO2, I always concentrate more on that. And I want that from external faculty also, they should know this thing, that it is one of the worst thing to have a low PCO2 for the future prognostic, as a prognostic factor. So well taken, definitely. This things will be taken into account. Thank you so much, Anuj.
Thank you very much, Prachi. Sorry, I was a bit harsh on you, but
Thank you, sir.
these are just
No.
cues for learning, and I hope you take it in a
This
positive.
is a very good way to chisel them out. Thank you so much.
Yeah, thank you so much. So thank you, Prachi. You had very well answered the questions and a very well presented case. So thank you for being there. Thank you so much, Anush sir, to going
Thank
into.
you very much for the opportunity, Kunal and Shwetal. Pleasure being here.
So you had gone into
Thank you.
detail and it has helped, and all the even now and even in the future, all this video will be there on the YouTube. So all the residents can see that and benefit from and learn from you a lot. So thank you, sir, so much again. Thank you, Shwetal ma'am, for being there and mentoring Prachi. Thank you, Nitin sir, for moderating this session. Thank you, ClearNet, Rupsa, for the seamless experience. With due permission, we can conclude this session now. Thank you so much, everyone.
Thank you.
Thank you.
Rupsa, Rupsa, I think we can leave this session, everyone, individually. Thank you so much.
Thank you.
So thank you so much everyone for extending us the opportunity to host this session. So with this, I would like to conclude today's session over here and looking forward to host you again. Thank you so much everyone.